I'm going to go ahead and get started just so we have enough time to get through the material today. Hello, everyone. My name is Elena Kidd, and I'm a program director with the University of Alabama at Birmingham School of Public Health within the Office of Public Health Practice. We're very excited to welcome you to today's webinar, The Mystery and Epidemiology of Long COVID, featuring Dr. Stella Ezebekian from 23andMe. This webinar is made possible by the Alabama Regional Center for Infection Prevention and Control Training and Technical Assistance Center, or ARC-IPC. The ARC-IPC was established to meet the consultation and support service needs surrounding infection prevention and control throughout the state of Alabama. The center is a collaborative effort of the Alabama Department of Public Health's Infectious Disease and Outbreaks Division and the University of Alabama at Birmingham. The ARC-IPC provides training and technical assistance to infection prevention and control and public health professionals in areas needed to detect, respond to, control, and prevent infectious disease outbreaks. You can learn more about the center, sign up for our newsletter, listen and view past trainings, request training or technical assistance, and view infection prevention and control resources at uab.edu/ARC-IPC. And you can also email arcipc@uab.edu with any questions. We would like to thank our co-sponsors for today's webinar, the Deep South Center for Occupational Health and Safety and the Region 4 Public Health Training Center. And you can learn more about their programs and centers as a whole on their website listed on the screen. We'd also like to let you know about a few of our upcoming webinars. Backed by popular demand is Dr. Katrine Wallace. Dr. Wallace has previously presented a webinar about misinformation as a risk factor during the COVID-19 pandemic, and she will be joining us again on October 13th at 12 p.m. Central Standard Time to go further into this topic and to also discuss strategies to combat health misinformation among your own friends, family, and workplace. This webinar will be presented by the ARC-IPC and co-sponsored by the Region 4 Public Health Training Center. Then on October 18th, we are hosting a webinar with Barbara DeBron, the ABCs of Viral Hepatitis, Update for Public Health Professionals. This webinar provides a snapshot of viral hepatitis epidemiology and an overview of the 2021-2025 U.S. National Strategic Plan and Roadmap for Elimination, which is highly relevant to the public health community. The webinar will include a discussion about current surveillance data that reveals trends, challenges, and opportunities, the importance of prevention through vaccination, and approaches to treatment for hepatitis. This webinar will also be presented by the ARC-IPC and co-sponsored by the Region 4 Public Health Training Center and the Deep South Center for Occupational Health and Safety. Continuing education credits have been approved for nurses by the Alabama Board of Nursing through the Deep South Center for Occupational Health and Safety for this program. In order to receive credit for this training, you must register for the training, watch the entire program, complete the evaluation following the program, and upon completion of the evaluation, you'll be redirected to the Alabama Nursing CEU request form, which you will also need to complete. CEUs will be awarded by the Deep South Center for Occupational Health and Safety. You do not have to submit directly to the Alabama Board of Nursing. Please allow 2 full weeks for us to process the CEU request. CE units for this program will expire on September 29th, 2023. If you have any questions or experience any issues, please email arcipc@uab.edu and we'll place this email in the chat box. And finally, it's my pleasure to introduce our speaker. Dr. Stella Ezebekian is a senior scientist in genetic epidemiology at 23andMe and an adjunct associate professor of epidemiology at the University of Alabama at Birmingham and the University of Kentucky. She earned her undergraduate honors degree from Stanford, followed by training at the Harvard School of Public Health and Brown University. Throughout her research career, she has focused on the nature and nurture question, how the genes and environment interact to determine disease risks. She has investigated this question in diverse populations using complementary approaches. Dr. Ezebekian's work has been funded by the National Institutes of Health and the American Heart Association. Currently, she works on integrating the large-scale nature and nurture data available at 23andMe to improve models of disease in human populations. So without further ado, it is my pleasure to turn things over to Dr. Ezebekian.
Thank you so much. And thank you for having me back at this venue. It's an honor and a privilege. As you said, I wear quite a few hats, some of them in academic epidemiology and some of them in the industry. And so today I will be talking about the work that I've done with my team at 23andMe. Now, usually when I say 23andMe, people say, oh, you're going to be telling us about genetics. And that's a fair question, but today I will not be telling you about genetics because it turns out that we have a lot of interesting non-genetic data that can help us better understand this long COVID condition that really has entered public consciousness not that long ago. So we're still at the very beginning of understanding it. And I tend to be pretty informal, so I probably will stop and take questions as I go along, particularly if the questions are relevant. Other than that, we'll wait and I'll answer questions at the end. So it'll probably be some kind of a mix of those two approaches. So what are we going to do today, especially if I figure out how this works? Well, we'll talk about what long COVID actually means. It's a condition that actually goes by many names, and long COVID is just convenient shorthand to denote a set of symptoms that persist in many cases long after the initial SARS-CoV-2 infection. We will talk about its epidemiology and etiology. So in other words, who gets it, why they get it potentially, how does it work? And we'll talk about whether or not we have effective treatments for long COVID, whether vaccines can help us resolve long COVID. And spoiler alert on that one, vaccines are great for prevention. They're not great for cure. That's not what they're for. So we'll talk about all those very live and ongoing scientific debates that surround long COVID. We'll start with the definition. And these are just a few of the names that you might encounter in medical literature. Sometimes those folks are called long haulers to evoke associations with long haul truckers as they're trucking through their disease experience. It can be called post-acute COVID, chronic, and so on. So any synonyms in that family, we will just today call them long COVID. But the idea, again, is that you have certain symptoms, and we'll talk about what those symptoms could be, that persist. They do not go away once that initial infection period is over. So here's a graph that we constructed using 23andMe data, and it gives you a sense of exactly what those symptoms look like. The most common one is in the top left corner, and it's brain fog. It's kind of a funny name, right? Especially I live in San Francisco. Fog is a daily feature of our lives. Well, brain fog is not nearly as beautiful. It's that sense of really slugging through your day when you're cognitively not fully there, when you're tired, right? Fatigue is actually the second most common symptom, but to me, it goes really hand in hand with brain fog. Shortness of breath is pretty self-explanatory, and that is our third most common symptom. And then you can see that there are many others that are ranging in frequency in our population. Loss of smell and taste is something that commonly comes up as a really distinguishing feature of both acute COVID infection, and sometimes it does persist. And then there's some very non-specific symptoms that really could be caused by many different things like anxiety. Related to that are heart palpitations, things like headaches. There are some symptoms that we also asked about that are not very common, so they're not reflected in this graph. But for example, we've seen reports of hearing loss following the initial COVID-19 experience, and we've also heard of disruptions of menstrual cycles for those for whom that's relevant. So what do all those symptoms have in common? They're pretty vague and they're pretty subjective, and they can be caused by a lot of different things. Probably the cleanest, if I may even use that term, symptom here is loss of taste and loss of smell. That's pretty easy to report and ascertain. But everything else, how do you know if this is brain fog because of your COVID infection or because you didn't get enough sleep or maybe for a variety of other reasons, right? And I have a question here. What is phantom smell? Phantom smell refers to a person experiencing smells that are actually not there. It's similar to phantom pain when we have somebody who's an amputee, but they're still feeling pain in the limb that had been amputated. So this is the smell equivalent of that. The smell's not actually there, but the person is experiencing it. And let me tell you, those smells are never the good kind. So as I was preparing for this presentation, I actually decided to dig a little bit into the history of this term, long COVID. I know I've been using it for a long time, but turns out the history is really, really unique. And I came across this paper that argued quite compellingly that long COVID, that term was essentially coined by patients, and particularly patients who found each other on social media and often had to deal with the skepticism of the medical community that such long-term effects even exist. And so the biggest question is, like, why did they call it that? How did this unfold? And it all started in May of 2020. So by that point, COVID is raging through the world. And a lot of public health authorities at that point are saying, this particular quote is from the United Kingdom, where the health authorities were saying that the great majority of those who experience COVID will probably have a really mild experience. In other words, it's not really a big deal. And here I'm just talking about COVID itself. But then something interesting happens. On May 5th of 2020, right around the same time that the official line of the biomedical community is that it's really not a big deal, an infectious disease professor from a well-respected Liverpool School of Tropical Medicine writes this opinion in the British Medical Journal. Again, if you're familiar with trying to get your research published in epi journals, the BMJ is one of the more selective ones. And he writes about his experience of emotions and exhaustion and brain fog and all those things, maybe not all of them, but a lot of the things that I showed you in that chart initially. And he's talking about that clearly having followed the initial infection and persisting for at least 7 weeks. And at that point, people start to listen because this is somebody who's not likely to make up that experience. This is somebody who understands infectious disease and how they work. And of course, this Guardian article, or I'm sorry, the British Medical Journal article goes viral. I think there was also one in the Guardian. And patients begin organizing, particularly on social media. And there is this really beautiful patient-led initiative that emerges that starts to track how those long-term symptoms unfold. And that starts just a couple of weeks after that initial report in the British Medical Journal. And so they have 640 responses from a survey that was deployed online and really tried to describe what that experience is like. And turns out that more than 3/4 actually came from a Facebook group called Body Politic. And then those were folks who were not necessarily only impacted by COVID or long COVID, but they may be impacted by conditions such as fibromyalgia, chronic fatigue syndrome, and so on. And we'll talk more about those later. And then from that one Facebook group, it went more or less viral. And you can see that this is all purely driven by social media. This is unusual because most of the time, such surveys are initiated by universities or big companies. And this was completely grassroots. And one really poignant part of that survey had to deal with the stigma and people reporting experiences that nobody believed them, that they're still suffering from those long-term symptoms of their initial infection. They are not even in some cases willing to admit it to themselves, right? Or they don't want to draw attention to those symptoms, particularly because they're so vague. And sometimes they even sound very benign, or sometimes they sound like things we all go through, like headaches and anxiety, right? That's just a feature of living in the modern world. And sometimes they're actually actively being discriminated, right? So people at work do not consider that a disability. So they're not getting time off of work. There are people who potentially even lost friends. Now, I don't know how good those kinds of friends are, but that is part of that experience. That is part of the report. And then when they're actually seeking help from the healthcare system, remember, this is still 2020. So the healthcare system is overwhelmed by dealing with acute COVID cases. And here are these people who have recovered from the acute case, but they're still suffering and they're still experiencing these things, and nobody's taking them seriously, in part because we don't have the resources, and in part because it's just not believed that it's a thing, for lack of a better term. So slowly but surely, enough of those patient groups have spoken up, and this is where scientific community does get credit for being open-minded enough to listen to the patients and to actually start conducting non-patient-led studies. And at some point, Dr. Anthony Fauci, also another respected figure, starts very publicly talking about those long-term effects. And this happened only a couple of months after the initial report. So this is a CNN article from 2020, July 9th. And at this point, Fauci is talking about those long-term effects as being quite real. And he calls it a post-viral syndrome. And he even connected it to those other conditions that I already mentioned, like ME or chronic fatigue syndrome. I have a question here from one of my former students, actually. This is very cool. Has the frequency of the symptoms in the clinical presentation changed through time with different variants? That's a really great question. And let me try to answer it right away. So we do know that one thing that really changes between different variants is severity. Like, for example, Omicron is widely believed to be less severe, at least in most people, than the initial Alpha and Delta variants. Severity is associated with the likelihood of getting long COVID. So the more severe your initial COVID is, the more likely you are to have those persistent symptoms. And we will talk about this. I will show you the data on that. So it is connected to variants in the same way that it's connected to severity, right? So because different variants confer different disease experience, they absolutely also impact the prevalence of long COVID. The clinical presentation may not be changing too much, but certainly the extent and the prevalence do change with severity. And of course, this is something that's very new, and as with any patient-led initiatives, there's a little bit of skepticism in the scientific community. So another respected journal, in this case Science, talks about there being no diagnostic findings that you could in some ways objectively define this long COVID syndrome. Now, they're not saying it doesn't exist. They're not saying people aren't suffering. They're saying there's no biochemical signature. They're saying there's no real scientific objective way to say, okay, well, long COVID means that this protein is elevated in your blood. There's nothing like that. In fact, the symptoms we discussed, they're quite nebulous and they're not signs of disease. So it's not like we're seeing bruises or we're seeing changes in blood pressure. We're actually just seeing those symptoms that are reported by the patient, and in many cases are perceived to be somewhat subjective. And it's not actually an accident that Fauci compared long COVID to chronic fatigue syndrome. So very similar discussions have been centered around chronic fatigue syndrome. Again, it's what it sounds like, except it's not just being tired all the time. I'm sure many of us in this room can relate to that experience, particularly those of us who were healthcare providers during COVID or those of us with young families. Chronic fatigue is not trivial. This is a kind of fatigue that means you can barely get out of bed. And you're trying, you're not lazy, you're doing all you can, you cannot even perform simple day-to-day functions. So chronic fatigue syndrome is something that clearly has an impact on people's quality of life. But again, because it's so hard to define, in a biomarker kind of way, a lot of times it's perceived as less than real. And if you go far back enough in the history of medicine, this isn't the first time. I mean, a lot of mental health conditions like depression and anxiety were not taken seriously until we actually had the neurobiological evidence that these conditions are just as biological as cancer, right? They're representing changes in brain chemistry that are very real. But unfortunately for long COVID and for chronic fatigue syndrome, such clear biomarkers, such clear biochemical changes have not been established. And that unfortunately hinders the recognition of these conditions by the broader scientific and medical community. But their recognition is increasing, and about a year from that initial Fauci statement and the initial article in the British Medical Journal, long COVID has been recognized as a disability under the Americans with Disabilities Act, which of course has positive implications in terms of being able to use certain company and public resources to take care of it. And it's quite staggering how many people are believed to have at least some evidence of long COVID. we're talking about 4 million full-time equivalent workers. And this is fairly recent data from the Brookings Institution, and that was also published on NPR and in the Lancet, which is a reliable journal. So we're talking about 2.5% or thereabouts of the US working population who are struggling with these symptoms. So of course, the human toll here is considerable. And for those who are more convinced by economics, the economic toll is also considerable. And I would say that we're at a point where it's no longer that controversial of a condition. We're seeing that it's there, but perhaps the exact clinical and epidemiologic vicissitudes of it are still to be worked out. So let's talk about that. Let's talk about the epidemiology and let's talk about etiology. So I really like this very comprehensive graph of what could be happening. And you can see that everything starts with initial exposure to the SARS-CoV-2 virus. It looks like a little spiky ball, kind of like the one you would put in your dryer with your clothes so that they don't crumble too much. And what we have here is we have viral load on the y-axis, and that's represented by the green and the hot pink lines. So the difference between the green and the hot pink is where did you get the virus from? Did you get it from somebody's nose and throat, or did you get it from lower in the respiratory tract? And you can see that if you're looking in the respiratory tract, there's really no more virus around week 2. But if you're looking at the nasopharyngeal SARS-CoV-2, it goes on and can go on for quite some time. And at some point, this person will stop testing positively on the PCR test, which is the gold standard for COVID. But it doesn't mean the virus has completely left their body. And at this point, we're starting to see many different manifestations of COVID. And I'm not saying it's necessarily caused by the virus itself. We'll talk about that. But you can see that you have, as I already said, fatigue, general malaise, general decline in life quality. You have a bunch of respiratory system impairments. So things like shortness of breath would fall under that. You have mental health issues, whether it's anxiety or sleep disturbances, and they put brain fog in that category. Because the lungs are involved, the heart will also be involved. You're having potential palpitations and chest pain, thromboembolisms, chronic kidney disease, and hair loss is also something we saw. I would say the one thing that's really missing from here that we see a lot of is that distortion of the senses of smell and taste. Can I speak to the higher rate of Americans reporting long COVID versus that of other countries? Well, many different reasons could explain that, partly because this is not necessarily an accepted condition. Elsewhere, I think in the United States, we've gotten to the point that people recognize it as a real condition. I cannot speak for every single other country. And in fact, in my limited international experience, there is a lot more hesitancy abroad to acknowledge those conditions. So I would say there's probably different patterns of reporting. There's also different patterns of medical billing. We actually now have an ICD-10 code for long COVID, and countries that may not be necessarily using those symptoms may be reporting it differently. So they may be actually reporting long COVID symptoms, but they're not calling it long COVID. There is a lot of variability in how these things manifest, but I wouldn't say that there's anything special about Americans. It's usually about how we collect the data and how comfortable we are even answering those questions. I think I have a couple more questions in the chat. So yes, some people are acknowledging the hair loss issue. And then there's another question, I think I've already answered it, whether long COVID symptoms vary from one variant or subvariant to another. I would say that because different subvariants confer different severity, the more severe your COVID, the more likely you are to have those long-lasting effects. So there is variation between one to another, but it's not like, oh, with Omicron, you get hair loss, and with Delta, you get chest pain. It's not like that. It's still pretty much the same constellation of symptoms, but the severity and prevalence can be different. So this paradigm where we have an initial infection that leads to chronic symptoms over months and years following the initial infection is something we've seen before. And here I want to refer to a very different kind of paper, but it still falls under the same paradigm. I don't know if you were aware of this, but in 2022, there was a real breakthrough paper published in Science about the etiology of multiple sclerosis. And the idea is that the authors, they're from the Harvard School of Public Health, they took data from the military, essentially, because we know that service members get tested for AIDS. So we have certain biobank samples from them. And if they consent, we can look at other things in those biobank samples. And so one thing they looked at was Epstein-Barr virus, so also known as the virus that causes mono. For any of us who've been to college, we're quite familiar with that whole condition, the kissing disease. So if somebody had been exposed to Epstein-Barr virus, that would be evident from their blood sample. And the authors were able to connect the presence of Epstein-Barr virus in the blood sample to downstream increased risk of multiple sclerosis. And it was a really dramatic change. So I believe it was a hazard ratio of 32. So that means that those with Epstein-Barr virus infection were 32 times more likely to develop multiple sclerosis. So, and you can see here, the incidence rate is plotted on the y-axis. So you can see that those who had infection had a much higher incidence of multiple sclerosis. So the question that the kind of data begs is, well, is it an autoimmune disease, like we are thinking of multiple sclerosis, or is it actually an immune disease? In other words, is it just that the virus is actually still hanging out in your body and your immune system is attacking it? Autoimmune means your body is attacking its own tissues. Your immune system is attacking its own tissues. That's what we see in multiple sclerosis. But there are scientists who say, well, maybe it's not autoimmune. It's just that we cannot detect the pathogen. The pathogen is still there. And those experiences, those symptoms that you're reporting, they're due to your immune system actually doing its job. So I already mentioned that we've seen that kind of paradigm of initial infection leading to chronic symptoms in the setting of EBV and multiple sclerosis, but we've seen it in other conditions too. And here I would like to recommend, if you're interested in that kind of literature, 2 books. Those are not hardcore science books, they're more actually memoirs. So The Puzzle Solver was written by a Stanford professor who has a son who is afflicted with ME, chronic fatigue syndrome. He has an especially difficult disease course. He's one of those folks who cannot even get out of bed in the morning. And if you Google Ron Davis, it's a really poignant story of a professor father really switching the course of his research and the focus of his research to be able to find treatments for his son. The son is still with us, but he's quite disabled. And his father, just here at Stanford, is trying very hard to better understand this condition and hopefully find treatments for this condition. And then another memoir is not by scientists at all. She's a writer, Persist, and she talks about her experience as a chronic Lyme disease patient. Now, that is one condition that's quite controversial. And nevertheless, when you read those memoirs, you realize that there's a real human experience. And while we figure out the science, it behooves us to listen to that human experience. So now let me show you some of the data that came from our own studies. I do want to first address a couple of questions that just came up in the chat. It appears that there's a wide gradient of symptoms. Do we have good data on prevalence and symptoms? Yes, we do. And in fact, I will, once I finish reading your question, I'll go back to that slide. This was a study of more than 100,000 people. So I would say this is good data on the prevalence of symptoms. And those folks came from all across the United States. Curious on the impact of repeated infections. That is an open question. This is not something I've personally looked at, but I would imagine that additional insults to the organism through those repeated infections probably do increase it. That's just a hypothesis. It's not data-driven at all. And you're reporting tachycardia post-infection. I wouldn't say necessarily, no disrespect to Mr. President, that the pandemic is over. It's not. In fact, I'm getting my booster shot today. So I would think that the risks of long COVID would be probably higher for repeat infections. But again, please do not base your life decisions based on my hypothesis generating on the fly here. And then the other question is really good. Do I know whether people who are vaccinated are equally at risk for long COVID? So they're not, because they're protected, because as I said, the biggest determinant of whether or not you will get long COVID is how severe your initial COVID infection was. And we do know that if you're vaccinated, you're more likely, even if you get COVID, it's more likely to be milder. So the vaccine actually does reduce your risk of getting long COVID by mitigating the severity of the initial COVID. And let's see, I think there might be some other questions now. Yeah, some people are just talking about their experiences with long COVID. And what's interesting is that the gender is coming up in these comments, and I will show you some data that indicates that women are more susceptible, and I'll offer some hypotheses as to why that is. And finally, another one of my former students and current TAs is asking, is there guidance that recommends nasopharyngeal over respiratory tract PCR testing after a certain time frame? Yeah, I think there's a real logistical issue here, right? That it's much easier to just swab somebody's nose and possibly throat. So there's no guidance, and that's not necessarily for scientific reasons, it's for logistical reasons. But I would say that if you're trying to really get into the pathophysiology of this, you probably should be doing different kinds of sampling. So let me show you some data that came from the study that I actually worked on, but I did promise that we'll go back and I'll show you the data on prevalence of symptoms. So I would say it's about a third of people are reporting brain fog, about a quarter are reporting fatigue. And this is again me relying on my memory. Clearly, I don't have brain fog. And then the third one is, I believe, shortness of breath. Yes, it is. And so that's also about a quarter. Fatigue is closer to a third. And then everything else is kind of between 10 and 20%, I would say, range. So this is the prevalence chart, if you're curious about that. So now this is one example of data that came from the 23andMe long COVID study. And I will talk about autoimmune disease as I'm talking about epidemiology and etiology. And so somebody asked a really good question in the chat, whether prior immune system or autoimmune diseases, immune system malfunctions, in other words, can confer higher risk of long COVID, and the answer is absolutely yes. So let me show you some of the things that we learned from our own study that I was privileged to be involved in. So initially, we were interested, being a genetic company, in the genetic determinants of who gets COVID and who doesn't. And we did publish the data. It was published in Nature Genetics, the first author, Schultz. And so this team deserves all the credit. They surveyed about 1 million people in the United States, and we timed those surveys to make sure that we're actually capturing states where there are high COVID numbers. And through that work, and that was the first work that 23andMe did in that space, we were able to identify which genetic markers are actually predictive of disease risk. So in other words, which genetic factors can help us understand whether or not you will get COVID in the first place, and whether or not you will lose your sense of smell or taste. So I'm getting a question in the chat is like, how can we distinguish symptoms from long COVID versus symptoms that may overlap with other diseases or conditions? That's very hard. I really don't have a good answer for you, right? So all we can do is we can ask people about those symptoms. Maybe we can try to ask about the timing of those symptoms. Did they start just now, or is it something you've been living with for a while? Another one of former students is asking about athletes. Working with them is obviously a challenge. So is there any information about the impacts of long COVID in college or professional athletes? That's a really good question. I'm not familiar with this literature just because it's really not my field. But I would say there's been such an explosion of COVID-related papers that just a PubMed search may be able to answer these questions. I think they're very valid. I think you could probably write a grant on that and get it funded. So again, coming back to the 23andMe study, so we had information on all these Americans who reported having COVID. And we are going to talk about the treatment trials soon as well. So we were able to recontact people who told us in that first wave of studies that they had had COVID. And we wanted to assess what their experience had been like, whether or not they actually had any long-term symptoms. And Kat Walton is a junior scientist in my group who led this analysis. So I just really want to acknowledge the immense amount of work that she's done to better understand this condition. And we got a response rate of about 10%, which is quite typical for us. I know it sounds incredibly low if you're in the social studies, but for us, when we're doing those really big web-based surveys, 10% is pretty good. And we ended up with about 100,000 respondents. And almost half of them reported experiencing something for a month or longer. So this is no longer under the auspices of just regular COVID. This is long COVID. And this is the definition that is actually commonly used in medical literature, whether or not your symptoms have lasted for longer than a month. Again, this is a reminder of what those symptoms were. Feels like we've reviewed that quite a bit today. But here's a new graph. And so this new graph shows the percent of people who've recovered from each symptom. And the different colors just mean different time points. So we ask those questions at 3 months, at 6 months, and at 12 months. Since the initial infection. And this is a big graph, and I want to spend some time here. So the first thing I notice here is that there's no 100% recovery here. So in other words, if somebody had cough during the acute phase, that doesn't mean that cough got resolved in everybody. In fact, there's still about at least 10% of folks who are still coughing 3 months or even potentially 12 months after their initial infection. And then, of course, the longer you look at the follow-up, the more likely the symptoms are to resolve. So that's why that orange bar, which indicates 12 months, is the highest, because remember, here we're looking at resolution. So higher is better. Higher means that the symptoms went away. So they do go away with time. And the more time passes, the more of them do go away, but it's not 100%. So there are people who are actively reporting these experiences even 12 months after their initial infection. And we don't have the data in our study, but there are now studies coming out from China, which of course was the epicenter of the pandemic. And they're seeing even over 2 years, similar disease or symptom burden. And then of course, it also, resolution differs by the type of symptoms. So cough is actually the one that's most likely to get resolved, at least within the 1 year frame. But some of the more neurological conditions like numbness or tingling or phantom smells or difficulty sleeping, as somebody mentioned tachycardia. So this is a little bit different. This is heart palpitations, but those are actually a little bit less likely to get resolved. So as you take in this graph, I will now look at the questions in the chat. So I do believe UAB has a COVID clinic. I don't know if it has a long COVID clinic. Maybe my UAB colleagues can answer in the chat if that's the case. I know there's certainly long COVID clinics where I live in California. So a few more questions here. Would this also include children, shortness of breath and headaches? So for ethical reasons, we only did the study in adults. So based on our study alone, I cannot speak of the pediatric experience. But surely others can. Thank you, Christine, for confirming that there is a UAB post-COVID treatment clinic. Again, maybe it's not called long COVID, but it does exist. A question off of something I said briefly, is there genetic research that to show that some individuals will not get COVID-19 at all? No, but there is genetic research that shows that they're at a lower risk of getting COVID-19. So, and when we're talking about lower risk, maybe their risk is lower by 10% or so. So your genes will not protect you. The vaccine would, and masks might, and those, we know what works. Genes may somewhat reduce your risk, but it's not something you should rely on. And then there's a question, what about those not get COVID, not vaccinated? I'm not sure what that means. So I'm assuming like those who did not get COVID, well, then they wouldn't be part of the study because we were specifically looking at only at people who did have COVID. And in terms of vaccination, well, vaccination prevents you from getting COVID, maybe not completely, but it severely reduces your risk of getting COVID. And so, of course, it also makes it easier with long COVID. And as I promised, I will talk about the treatment question, so I'll keep it up here. So what were the things that actually made people more likely to get long COVID? What was really nice about our study compared to some other studies is we looked at people who had mild COVID, we looked at people who had severe COVID, we really looked across the entire spectrum of disease severity compared to some other studies that were rooted in a medical system. And so they only captured people whose symptoms were bad enough that they went to the doctor. And they also had access to the doctor. So we're really getting everybody in this study. And by far the most severe risk factor for long COVID is hospitalization. So I already said this several times, the more severe your COVID, the more likely you are to have those long-term symptoms. And of course, hospitalization is just about as severe as it gets if one survives. Now, we do have genetic data, so we're able to figure out who is XX and who's XY. So most XX individuals are women. And we did see a twofold increase. So even though we looked at it from the standpoint of genetic sex, here I will just say women for simplicity, but that's what it means. It actually just means XX karyotype. So women were twofold more likely to have long COVID compared to men, even though men are traditionally more likely to get COVID in the first place. But women were more likely to have those symptoms persist. And then prior disease. So again, the nice thing about the 23andMe database is we had reports of what other conditions they had far before even the COVID pandemic started. So we were able to prospectively connect those things and say that cardiometabolic disease, autoimmune disease, which somebody asked about, and also depression and anxiety were all factors that increase the risk of long COVID. So I have Lauren, a lot of really familiar names in the chat. That's really beautiful. So 2 questions here. Could I tell if those that suffered from long COVID had more comorbidities generally compared to generally healthy people? So I think that slide answers it. The answer is clearly yes. And men were more likely to contract COVID-19 due to how they store body fat. They're less likely. So the body fat hypothesis is interesting. I think a lot of it had to also do with behaviors. I can show you some interesting data in terms of those gender differences. I've never seen the fat distribution hypothesis. That's interesting. And I will say a few more words about why we think that specifically XX individuals are more likely to have long COVID. It has to do with women in general more likely to have autoimmune disease. So if this is autoimmune, this does bear out this story. So any information on those who haven't had COVID at all, but were exposed, super dodgers, the problem with super dodgers, they're just really hard to capture because how do you even know? I haven't had COVID. I've never tested positively for COVID. I don't know if I'm a super dodger or not, right? So we haven't specifically studied their genetics in part because it's so hard to ascertain exposure. How do you know? Maybe you just had a super mild disease course, right? So maybe you did have it, but it was super mild. And maybe that's interesting to study. So I cannot say much more about that at the moment. I think that's a worthwhile hypothesis. And thank you. Of course, we do try to be inclusive, but not just inclusive, but also scientifically correct. Like here, we did ascertain XX karyotype. So, and this actually matters scientifically here because it is that second X chromosome that confers the additional risk of all autoimmune diseases. I will say more to that. And of course, people of different genders could have 2 X chromosomes. So does an exaggerated immune response or continued inflammatory response play a role in long COVID symptoms? We think so, right? I think that's kind of where we're going with this in terms of the field understanding it. But let me talk a little bit more about this potential biology underlying these associations. Those are all really good questions. We ascertained long COVID a little bit differently. We asked them, were you ever diagnosed with this compared to have you ever experienced it? And when we just restricted our analysis to the diagnosed group, the associations were stronger. I promised to talk a little bit about vaccination, and I think the message here is on the slide. So vaccines are great at preventing severe COVID, and by doing so, they also prevent long COVID. But if somebody got vaccinated after getting COVID, it doesn't mean that the vaccine will resolve their long COVID symptoms. The majority of people actually didn't experience any changes to their long COVID symptoms, but then some did report improvement, and a very small percentage of people actually reported worsening of long COVID symptoms after vaccination. Again, they were small, but they were there, and that's an interesting experience that I think is worth noting. I promised to say a little bit more about biology, and so here we are. And so why do we talk about XX individuals specifically and not just women? Well, because there's a second X chromosome there, right? And normally it gets deactivated because you really don't needed, and I say that somewhat facetiously, but there are genes that escape this deactivation process of the second X chromosome. And specifically, we know that a lot of the genes that are involved in the immune system are on the X chromosome. So if any of them are escaping X deactivation, you essentially have this phenomenon of the immune system being in overdrive. And that's why this is not our graph, and it should really say XX versus XY. And so you can see that for some of the autoimmune conditions, and these are all autoimmune conditions, for a lot of them, XX people are just really overrepresented here. So for something like Sjogren's syndrome, it's more than 90%. For lupus, it's more than 80%. So women and XX people generally are at higher risk for just about anything that's autoimmune. And long COVID does not seem to be an exception if we were to believe that this is an autoimmune condition. We found a lot of things that corroborated what other researchers are currently reporting. Now, we would still love to understand this whole XX situation. We would love to understand more the immune system, which some of you were asking about. For example, there was this great study that Fauci talked about. People with allergies. And what does that mean? Well, that means their immune systems are a little bit on guard for anything that could be entering your body, right? So if they're allergic, they're overreacting to these things. And those people are actually a little bit protected from COVID-19 itself. But if they do get long COVID, which of course does happen, they're much more likely to progress to long COVID because their immune system is already hyperactivated. And so that leads to this prolonged presentation of symptoms. Mental health conditions are also really interesting, in part because if you're curious, Google is depression an autoimmune condition, and you'll find a lot of interesting literature that shows that it very well could be. If you're looking at genetic studies of depression, a lot of genes that light up on scans for depression actually are involved in the immune system. So there is a school of thought that I think is really interesting, and that's emerging, treating mental health conditions as another facet of the immune system. Of course, not only the immune system, but maybe it would be more accurate to say that the immune system is believed to be at least somewhat implicated in mental health. And that's a really active area of research right now. And this is some of the biology that could be connecting our emotions to the central nervous system, to different hormones and cytokines and neurotransmitters. And of course, that is also connected to the immune system. And you can have different insults coming from infections, so trauma or COVID would be one example of such infection. And we really have some pretty good evidence that these things are connected. Mental health is connected to the immune system. And in fact, we do have an FDA approval for an SSRI, in other words, an antidepressant, that is given to COVID patients to prevent severe outcomes. This is not necessarily to prevent long COVID, but we have evidence that giving people antidepressants helps them have a milder clinical course of the COVID-19 disease. And women do have higher rates of anxiety and depression. That is absolutely correct. I will say that when I presented those numbers, that was already adjusted for sex and age. So even though women have twofold higher rates of anxiety and depression, or higher rates, we controlled for that. So when I'm showing you that twofold increase associated with anxiety and depression, that's just anxiety and depression, that's not gender. So for those of you asking about treatments, again, this is not something that's necessarily been yet approved for long COVID, but I think that's potentially an interesting area of inquiry. And so let's talk a little bit about treatment. So we've talked about those antidepressants, we've talked about vaccines, and vaccines, again, are not a treatment. They're great at what they do, but they do not treat. And Paxlovid is an antiviral drug that's usually given to people to mitigate their clinical course of COVID itself. So of course, if you can make your COVID milder, it makes sense biologically that it will also decrease long COVID. So Summer in the chat is reporting her experience that it really worked for her. So I'm really happy to hear, and it makes sense to me biologically that it would work. So thank you for sharing that experience. Somebody's saying, Abigail is saying, it makes them wonder if people on antidepressants already are less likely to have severe COVID outcomes. That's also a possibility. And I'm not familiar with research specifically answering that question, but I wouldn't be surprised if that's the case. Were other SSRI studies? Well, that one is the one that's been approved. I cannot tell you because it's possible that they're being studied right now. Super Dodgers, multiple exposures and negative antigen testing. And yes, I think studying superdaughters would be very interesting. But this is more about long COVID, so I don't want to spend too much time on superdaughters, but I want to validate that experience. And I think in general, those kinds of outliers are very interesting biologically and epidemiologically. Is this long COVID? Well, long COVID does not cause reinfection, but it does weaken your immune system. So you could become potentially more susceptible to reinfections. And wearing a mask is an evidence-based strategy to mitigate your risk. So probably a good idea if you're in that group, especially. Were there any data discussion of individuals with mast cell activation syndrome and long COVID? Absolutely. Again, I cannot point you right now to specific data. That's not something we looked at, but I am familiar with that. Again, it's kind of sits in that group of conditions with CFS and fibromyalgia. So this is something that I think is also an active area of research. Now, the other thing, what's hard about long COVID is that long COVID looks very differently in different people. So there is actually a belief that maybe long COVID can have multiple causes, right? In one person, maybe they have an autoimmune condition. And so then their immune system is being attacked by SARS-CoV-2. And that's interaction between their pre-existing autoimmune condition and SARS-CoV-2 creates long COVID. So that's one cause. Maybe it's something more through the metabolic pathway or the respiratory pathway. So maybe we don't need one treatment that helps everybody, but we need tailored treatments that help specific manifestations of long COVID. And I would say that most of the time, what you're seeing now when you're looking at treatments is mostly to treat the symptoms rather than long COVID itself. And quite recently, there was a big editorial in Nature essentially lamenting how few treatments we have at this point. So this is a summary of 26 trials that are currently testing different therapies for long COVID. And again, some of them are addressing things like blood clots that could potentially kill you. So it's really important to treat that particular symptom. And then I already mentioned fluvoxamine that have a more systemic course of action. And some of these studies are actually repurposing drugs that have already been tried for other conditions. We've seen that happen for COVID itself. And I think that's a pretty good approach when we have a new condition. You want to see, well, maybe we already have tools that can address it effectively. And it's kind of hard before you start a trial to figure out, well, what kind of long COVID will this person have? So this is really hard to do. There are some really innovative treatments like this Resolve Therapeutics one, where they're actually looking to remove the actual viral RNA from the blood. And there are some really preliminary evidence that that could work. So this would be an example of something that may work across a range of the long COVID experiences, but again, very much in the beginning of that particular journey. And I would say in general, we really don't know at this point how to treat long COVID, just like we don't really know how to treat chronic fatigue syndrome. And in part it's because we hadn't been taking it seriously for a very long time. And it takes time. I do think now the medical community is in a state of acceptance and commitment to finding effective therapies. And I do hope that if I'm ever invited to give one of the seminars again, I'll have a much more optimistic slide to end on. But this is where we are. And I just want to thank my team for working with me on all those COVID-related original data analyses. So it's always nice to present data that you've actually worked on and know backwards and forwards. And I'm seeing some really interesting chat comments too. So thank you for your engaged presence here. Stress levels in long COVID. Hi, Eva, my former student. I'm here many potential stories. I do think that because stress can dysregulate your immune system through kind of a more anxiety pathway, it probably is a factor. And thank you for sharing the body fat paper. Vertigo is something, and dizziness is something we're also seeing. And thank you all. Thank you, Lisa. Thank you really all. Bay Area, yes, so of course my contact information is available from the seminar organizers. If you have any follow-up questions, I'm open to that. Thank you. I'm really getting a lot of positive feedback here in the chat. So it's always, as I said, an honor and honestly a pleasure to be here. And we had a really good group here, and it's just really nice how people really asked great questions.
And thank you so much, Dr. Azalekian. That was very informative, very well presented, as great. So a lot of great remarks in the chat box, and we're just very thankful that you were able to join us again.
Well, pleasure's all mine. Thank you. I see lots of little emoji.
And we did have one more quick question come in.
Oh yeah, let's see that. The timing worked out really well. How do you participate in this kind of study if you work at the health department? Well, this particular study was actually just for the 23andMe cohort, because this is a cohort that we already consented to research. So these are people who are involved with the 23andMe product and have consented to participating in our research. So this is not a health department initiative. This is a private industry initiative.
All right, so I know we're getting close to time. Just as a reminder for everyone listening, we are going to be sending out a recording to this presentation along with the evaluation link and slides next week. And if you have any questions, you can contact us at arcipc@uab.edu. But if there are no other questions, then I will bid everyone have a great day and have a great weekend. And again, thank you so much, Dr. Ezlikian. We really appreciate it.
Thank you for having me.
Thank you.